Картинка эндоскопично есть, да? Так, нас слышно. И вас тоже. Хорошо.
Baskı buskopan. Baskı pen. Ha. Bir buskopan yaptırabilir misin? Pazmomen.
Buskopan mı?
Which is the... I'm sorry. The lesion is here. Okay. Okay. The lesion is here? Okay. Okay, okay, okay.
We will check it again. It will be better. Виталий, мы чуем вас добре. Ви славите, чути нас? Так, нас чути, вас чути, Віталій. А от. Sen gibi o şey gibi düşünemezsek.
Ben soruları tam duyamıyorum. Sen duyarsan şey yap.
Да, он слышит, только слабо, но слышит.
Yeah. Okay. Okay. The first examination, this patient says contractility is here. So for good elevations, the depends on the situation. I prefer to use basket pen generally, and half ampoules, and then starting the procedure depends of the situation. I prefer use the again half ampoules, 20 milligrams or 40 milligrams. That's enough. But some authors prefers to continue injection, 2 ampoules and insert the saline solution 500 milliliters, and during the procedures maybe given these patients, but I don't prefer this approach. The other lateral spreading tumors is here. This is the hepatic flexure. I guess the This is the granular mixed type lesions, because the lesions have the large nodules. Those lesions locate on the upside position, this on the hepatic flexura, and one of them is here. This is the for the ESD. It's a good indication for those kind of the lesions. The other lesions is backside, small polyps. For those polyps, cold snare resection may be used, because not bigger. And the other lesions,
What about distal cap?
yeah. For examination, distal cap is most useful, but the first examination, when the distal cap using, sometimes may not be seen. The lesion may not be seen, because cap is more useful beyond faults, but for the initial examination, no need. The other lesion is here. Evet. For this lesion, EMR can be performed. And additionally, the other lesion.
The question from audience, when first surgery was done, it was in February.
Yeah. Which is the first approach. Yeah. Okay.
Please tell them that surgery was done in
February,
February.
yeah. Okay. February 2019, this surgery was done for this patient because of rectosigmoid cancer. Nerede? Yeah. 2 lesions. 2 tane. 2 lesions. Yeah. About 5 lesions. This is the anastomosis line. Is clear. In this now, we cap fitted the colonoscope. First approach, the hepatic flexura lesions will be removing now, because this is problematic lesions. When the lesions invasive cancer, I don't think so. The invasive cancers, so when this happen, maybe surgery repeat. But the lesion intramucosal cancer or adenomatosis polyps, so follow up, that's enough for this patient. Generally, soft cap for colorectal procedures is appropriate, but sometimes the lesion has a fibrosis. Sometimes the lesion difficult approach this the lesion. Sometimes the knife perpendicular muscle layer. When this happens situation, the conic caps of short caliber caps, fibrotic caps can be preferred. Okay. Şey var mı? Oh, sorry. One more. One more. A little bit length. Okay. Okay. Right. A little bit looping formation. Okay. This idiom. Yeah. This is gravity side is here. The polyp is here. With the MBI mode, no. At first, we will try to this position. It depends on the gravity and movement of the knife. So position may be changed. Now this gravity is here. So at first, this area will be mucosal incision will be now, and then extending to iliac side. Probably this problem is here. This knife is perpendicular, right? So when this happen, the suck to gas, the mucosal the lesion approach the scope, close the scope, so dissection will be better. Okay. Hangi solüsyon? Which solution? Gel. Yes. Scope straight of the scope. This is very important because paradoxal movement easily perforation easily can be done. So at first the mucosal incision, mucosal injection was made. This is the scope position. It's difficult. I'm sorry. So, we have to stabilize. Okay. Skopu pozisyonu düzeltmeye çalışıyorum da. Ya, verelim. Inject. Okay. Okay. Allah is. So lesion size small, so everywhere can be made the injection, no problem. And then we'll start to incision. Okay. Normalken. 1,5. Kolon için. And we will use the dual knife 1.5 millimeter regular type knife. This is injectable knife or not injectable? Injectable knife. For mods, as you see here, pulse cut, fast, and power coag were used. Effect 2. This knife is dual knife 1.5 millimeter injectable knife. I'm sorry. This. I'm sorry. Okay, we are ready? Yeah. With mucosal incision, sorry. We have a kosher problems. Sorry to bother for late procedure. Okay, we start. As you see here, the muscle layer, so very uh, closer, so no problem for us. This is the power cog mode. Yeah, because the lesion size less than 5 centimeters, but the lesion located the upper side position, so the approach is difficult because knife is perpendicular to muscle layer, as you see here. So when this happened, the pocket creation method very useful. As you see here, the submucosa. Generally, the rich vascular area, when this passing, I prefer the power coag mode, as you see here, and easily coagulated when this bleeding can be performed. And the other area, I prefer to use cut mode. Is there any question? Yeah. Rusça, no, no. Only problem is scope movement because this depends on the lesion upper side of the hepatic flexura. Probably, but in this area, in the inside, for instance, the lesion located is here. This retroflexion position is good, but the upper side, unfortunately, the thin scopes need because easily perforation when this happens. If you were the Russian question, because okay, okay. As you see here, the fault, house roll, and the mucosa, and the vascular area. In this area, very thin, because so easily spontaneous perforation can be done. So every time we have to suck the gas. Suck the gas is using the muscle layer thick, but air inflation, so muscle layer very thin. So every time when this situation, gas have to suck. Huh? Yes. Generally in this area I prefer this narrow cap, but for this patient no need, because easily approach the submucosal layer as you see here. This is free area, so movement is easily. Inject. I'm sorry. No, generally in the right localization, I don't prefer to ephedrine, because after the procedure ischemia is a big problem. Inject. Only rectum I prefer, because anal canal and rectum very riches in terms of the vascularity. Additionally, as you see here, muscle layer, inject. Muscle layer and submucosa. Inject. Okay. Uh, Contraction is problem. Peristaltism. A little bit. Yeah, buz kapağı. Inject. Okay. That's enough. As you see here. In this now, we will performing the circumferential mucosal incision will be performed. At first, this part will be dissected now. No. Probably, but no need because that's enough. The submucosal space. Problem is approach because limited movement of the scope. Inject. Very seldom, but in the rectal lesions, very dense vascularity. So, and the big lesions, I prefer it. Oh, sorry. Biraz daha yaklaşalım. Öyle yapalım çünkü yaklaşım problemi var. Olmazsa change the position. I'm sorry.
viruses.
Yeah.
Audience suggests to add some more injection.
Yeah, probably, but no need because that's enough. It is in this now. The submucosal injection much more. Sometimes easily muscle layer, past muscle layer. So probably when this happen, easily separated can be developed. Inject a little bit, but the cap pressure, so the submucosal fluid easily disappeared from the cutting area. Inject. Okay. I'm sorry. Yeah. Scope moment is difficult. Is there any question? No. When the vascularity area, coagulation mode. Inject, inject, inject. Inject. Arterial case. Unfortunately, don't stop. So we need to progress. But when this happens, at first, the cap pressure, because submucosa 40 soft coagulation. Yeah, soft coagulation, that's enough. 50 and effect 4 or 3, that's enough. Açalım. Come. Let's stop. A little bit pull back. And blanching, that's enough. Just a moment. The other large vessels. Okay. You can take. Grasper. Yeah. The other side is when this section, so bleeding can be seen. Okay. Tamamdır. No problem. Bıçak. Inject. Inject. Okay. In this now, we will change the position, but we will, after the eject, okay. No, a little bit area was remained, as you see here, because the lesion is almost the dissection was be completed, but a little bit area was remain. So this area, after the change the position, will dissect. Okay. The no, left. Yes. Sorun yok. Tamam. Aklına takılan bir şey var mı? Bana da şey yap da unutmuş olabilirim. Duymamış olabilirim. As you see here, the supine position, the lesion is here. So the other side will be dissected now. Inject. Inject. Do you have any problem? For okay, okay. O da olur. Da şurayı bir almam lazım. Okay. Inject. Got this problem. No problem. Evet. Odur. Enjekte versene. Tamam.
Good morning.
Yeah. The procedure was completed. As you see here, the muscle layer intact, and preventively coagulation will be done. Closing or not? What do you think about this closing, Yakovenko? Duyamıyorum ben.
Yeah, he suggests better to close because the patient is from other city and
Yeah.
we're not sure about the
Yeah. But Japanese guideline, Japanese authors say that when the patient, if the patient has a taking anticoagulant drugs, so closing should be performed. But muscle layer injury probably, or coagulation much more use. When this happen, preventive to delayed perforation, closing maybe should be done. The other times, no need. Kograsper for the prevent.
Dr. Yakovenko suggests that in this case you better use the retroflexion to stabilize the breathing movement and peristalsis.
Yeah, absolutely. This probably sweet, but unfortunately we tried this retroflex position. This patient history of surgery, so probably this bridge for fibrosis. Don't force this retroflex position. 2 or 3 times I try it. Unfortunately, not sweet. But about 6 or 10 months ago, EST scope for Olympus, thinner, 11.1 millimeter diameter, so easy retroflex position. Most of the Japanese authors have been using the scope. Unfortunately, PCF, not PCF, not PCF, only EST. Much thinner and much flexible. Okay. Açalım. Okay. Tamam.
Sol tarafta. Gelip.
Ha. Okay. Okay. I'm sorry. Which alabilirsin? Small regions. Sound. For EMR, maybe option. A little bit saline. Ah, yeah. For training, bigger lesion, not sweet. Okay. Okay. Because the procedure time, there are a lot. Depends on the lot situations. Right. Unfortunately, this is a. Ah, okay. For the other lesions, polypectomy may be used. The same. No, no, no. 10 or snare, 15, 10 or 15 millimeter or 10. Injection and standard EMR. Standard, that's enough. Okay, okay. Okay, for injection. uh, Probably that's okay. Cold strain may be used, but uh, one EST procedure was done, and uh, probably the last lesions for EMR, and the other lesions cold snare. When does the bleeding? Which is the resected area? So I prefer this condition. The classical, conventional techniques may be used, maybe better. Standard snare, that's enough. Generally, stiffness snare much better because open, inject. Okay. Okay, inject. That's okay. İçine ya. A little bit injection, that's enough. Open. But sometimes uh, uh, big lesions underwater EMR close, slowly close. Underwater EMR much better. Why? Sorry. The other. Okay, open. Open. Slowly close. Okay.
Bir tane kocamanı kaldı.
Evet, onu alacağım şimdi.
Onu backup gibi alsak nasıl olur?
Olur. Bir bakalım.
F0 için.
What do you think about underwater EMR? Yakovenko or Vadim?
It's very useful in some cases.
Which kind of lesions? Yeah. Generally, underwater EMR may be less the perforation because the suction the gas and the full the water, muscularis propria is straight position, only involving the mucosa and submucosa. So when this happen, when the underwater EMR performing, the perforation less common compared to conventional EMR. In conventional EMR for injection and mucosa flattened and enlarged, so capturing the snare is difficult. Where is the other lesions?
Az kaldı. Şurada olması lazım. Bir var.
Ah.
Burası ne? Bir tanesi de var.
This is the flat type lesions. Inject. For this lesion is standard conventional EMR methods will be used. This is a non-granular type lesions. So, in my opinion, precut EMR will be better. What do you think about this? Snare. How is the precut EMR? will be made. Snare alayım.
Yeterli mi?
Tamam. Şimdi açacağız şunu. A little bit.
Şöyle iyi mi? 30-20 iyi mi?
Yeah, okay. Tip of the snare we're using as a knife. This method is better compared to better than the conventional EMR. Okay, açalım. Slowly açalım. Okay. No, no, directly. Soft. Evet. Tamam. Okay. I guess procedure was completed. Is there any question? I'm sorry. Two. Uh, yapalım. No, this is I don't know. for those kind of this polyps, cold snare may be better, but to in as order to for EMR and the other lesions. Okay. Prefer this conventional polypectomy method. The other side. Okay. Okay. Tamam. Okay. Okay. Hadi. Şuraya. Okay. Okay. Yes. Okay. İçinde. Inside the working channel. All polyps were resected and procedures were completed. Yeah. Ha? Yok, orada çekimde yoktu ya. Yok, çekimde yoktu. İlime girdik. Ha, doğru. Ascending colon. Neyse, tamam. No, gerek yok. Tamamdır. Okay.
Ne zaman çeker yapacak?
6 months later, the colonoscopy will be performed because the small polyps everywhere. As you see here, lateral margin were clear. And this is the lateral spreading granular type lesions. About to 30 millimeters. Closer the MBI. Close. Okay. Probably this is tubulovilous adenoma with low grade dysplasia. What do you think about this surgery? Okay. For those kind of the lesions, EMR, piecemeal EMR, underwater EMR may be performed, but the recurrence is big problem. More than 2 centimeters lesions, and according to Australian study groups, the odds ratio 2 times recurrence rate, and more than 3 centimeters 4 times, and the more than 4 centimeters 8 times recurrence was found. So if you have experience a center, for instance this center, for those kind of lesions, EST may be better. Okay, is there any question?
I think we can go upstairs and they can ask the questions direct.
Okay, okay.
Thank you very much.
You're welcome.
Thank you very much.
You're welcome. Thank you very much. It's really nice assistant. Very nice supporting. Ah, sorry.